I've been fortunate to be part of, on the very sidelines of the development of the ILC and watch the significant changes that have come about over the years, and it is very impressive. So thank you very much for all your hard work. So I'm going to speak today. The title of my talk is A Process Approach to the Management of EDS and Hypermobility Spectrum Disorders. I'm first a kinesiologist. That was my primary sort of profession that I've practiced in for the last 20 years, and then I went back to school 10 years ago to become an osteopathic manual practitioner to add the manual therapy component to what I do. I work clinically in a physiotherapy clinic in Oakville, and because of being introduced to EDS via the community that I'm in, most of my experience, again, comes clinically, applying the knowledge that I have and finding other tools to help work with this diverse population. So the connective tissue puzzle. First of all, I have to give credit to the picture for my daughter because she said my presentation was too boring and I had to add some pictures. So there's my photo. But a puzzle, I find, is a great analogy to the EDS population because we have the framework, we're starting to understand what that represents anatomically, physiologically, all the systems. But then the middle of the puzzle really represents the diversity of this population. So even in my clinical experience, someone might come in with this diagnosis or something along the spectrum, but how that manifests for the individual, what their life looks like, what their day-to-day function is very different. So I propose that we need to work towards a therapeutic alliance with patients and professionals working together to find creative and effective treatment solutions. So as far as the manual therapy community, that tends to work very much in private practice, helping to build those alliances with their patients, but then with the medical community as a whole. So the objectives of my talk today is to look at a change to the therapeutic model that we tend to apply in manual therapy, a change from a very structured, centered approach to treatment to one that's process-centered. And I want to talk about managing the health spectrum for the patient with EDS and HSD, and what the role of manual and exercise therapy can be within an integrated healthcare team. And I do like quotes, so this is my first quote. Variability is the law of life, and as no two faces are the same, so no two bodies are alike, and no two individuals react alike and behave alike under the abnormal conditions which we know as disease. And this is by Sir William Osler, and you can see when he was alive. And so to me, I think we could substitute disease with EDS in this quote. I think that it's applicable to many conditions that we see. But I also found it of interest looking at who he was. And he was the first physician to take medical students out of the lecture hall and bring them to do bedside clinical training. And he was the first to also start specialized residence training with physicians as well. So what I did for this talk today is review some of the most current literature that's just been published in 2017. And this one's from the International Journal of Osteopathic Medicine, and it's titled A Process Approach in Osteopathy, so you can see the inspiration for the title of my talk, Beyond the Structural Model. And it's written by Il Lederman, who is quite prominent in the osteopathic community, but in manual therapy in terms of really studying the effects of manual therapy to prove what it is that we're doing. So in his talk, he refers to the structural approach, which really can be related to the biomechanical model that we sometimes use in manual therapy. And he says that that approach to treatment compartmentalizes symptoms and applies usually a single mode of treatment to fix the problem. So taking whatever symptom or signs and trying to find that one solution. Whereas multisystemic disease presents with a complicated manifestation, having physical, psychological, cognitive, behavioral, and social components, which would apply itself to the biopsychosocial model that we know. So in his article, he presents this schematic, which represents the 3 recovery processes that are active in healing. And in this case, he's talking about musculoskeletal and pain conditions, and he says that they can be associated with 1, 2, or all 3 of these. Repair, which is repair in tissue. Adaptation, which is multisystemic, that can involve vascular, lymphatic, and neurological elements. And in the alleviation of symptoms, which can be a mix of biological, psychological, and behavioral factors. And he presents a few examples, but I extracted this one in particular, which was looking at the processes involved in the recovery from acute and chronic low back pain. So in the acute model, we can see that the repair of tissue, can represent a large portion of the healing, whereas the alleviation of symptoms and adaptation aren't quite as prominent in that process. Whereas we move along the spectrum towards a chronic condition, repair, suggesting that anything sort of beyond the 3 months period, that the repair of tissues has happened, but now you're dealing more with the alleviation of symptoms and adaptation. And in his schematic, he points out that the area in the center, where those circles overlap between the alleviation of symptoms and adaptation, and you can see how small it is here on this side, that represents central nervous system plasticity and the role that plays in the healing process. So I guess the one last thing is that even though we have this spectrum, that our EDS population can fall anywhere along there, depending on what issue is happening. So we'll have that person come into our clinic that potentially is dealing with a lot of chronic issues, but there can be, again, spontaneously new things that arise. So we have to have the ability to work along that spectrum, to use different tools in order to address some of those different issues. So he proposes some practical application that can be used for manual and exercise therapists, which is to develop realistic strategies and functional goals that reflect the patient's movement abilities. The focus on pathways and opportunities for self-care, independence, and autonomy, and that recovery occurs in the patient's environment and during daily activities. And I do agree with this in a sense that we don't always have to have the patient in our clinic in order to provide care in a way, that some of these things can be implemented in terms of daily activities becoming then the therapy in and of itself. I've been known to do Skype treatments as well for those that can't make it. So there's ways to teach, educate. As an exercise specialist, I do a lot of exercise instruction, so I don't always even have to be physically with the individual. So part of it is working with the tools that they have. So the next article that I'm going to present, again from the International Journal of Osteopathic Medicine, is called Integrating Osteopathic Approaches Based on the Biopsychosocial Therapeutic Mechanism. This is part 1 of the mechanisms. There's a second part on the clinical approach, and this is by Gary Fryer, and he's a DO in Australia. So a similar concept, just a different schematic that he presents, which is that there are psychological and biological factors in somatic pain, and then looking at the application of osteopathic management. So he talks about the bottom-up influences, which are the biological factors, tissue factors, neurological, and then those top-down influences in the psychosocial factors. So some of the things from a manual therapy point of view that we're doing with our treatment is to look at helping a tissue healing and adaptation, improving movement and flexibility, and improving fluid flow and drainage, modulation of pain, desensitizing threat reduction, sensory motor integration, and to increase motor precision. And then from the sort of top down in terms of pain management, there's other tools that we have, which is your reassurance and education, reduction in fear and anxiety, confidence in movement, and the encouragement to be active to help with patient empowerment. So depending on what system we're looking at in terms of acute or chronic, that schematic can change. So on the left, we're looking at more of an acute somatic pain, whereas on the right, we're looking at a chronic condition. So like Lederman, showing that the biological factors in the acute setting, that they represent a larger portion, specifically the tissue factors. So injury and inflammation, healing and repair, peripheral sensitization, lack of extensibility and mobility. And then whereas we get towards the chronic, and we can see those top-down influences representing a bigger component. Not that one is absent, but again, the spectrum in which we're working from might change. And even though, again, I'm presenting research from the osteopathic community, it really does apply to manual therapies, physical therapies as a whole. So some of the treatment outcomes that he's looking at in terms of from a manual therapy point of view are the neurophysiological pain modulation to improve sensory motor and proprioceptive integration. That treatment can cause an autonomic response in both the sympathetic and parasympathetic systems depending on the techniques that you use. And education represents, again, another portion of that treatment, nature of pain, empowerment, and self-care. So the last article from the Journal of Manual and Manipulative Therapy is titled Manual Physical Therapy for Chronic Pain. The complex whole is greater than the sum of its parts. And that's by Coronado and Bialowski, and they're in the departments of physical therapy in Texas and Florida. So I took some of their descriptors from their article about pain. Pain is an experience orchestrated by dynamic sensory, cognitive, and affective processes, and is strongly influenced by a patient's expectations, mood, desires, and past experiences. And that a comprehensive approach is required for the integration of adjunct interventions such as psychosocial strategies and exercise that can enhance the effectiveness of manual therapy for reducing pain or to promote positive behavioral change. So with those concepts, now to apply it to our EDS population, we're really looking at their spectrum of health and how we're trying to assist them to move from the decreased function towards more optimal health. And that because this population is dynamic and that the symptoms and experience change daily, the big thing that I always ask myself is, what can I do for this person today? What do they need from me? And that the education and problem solving in the relationship is to help increase the tools in the toolbox for both the patient and the practitioner. We're working together to find solutions where, again, sometimes the solutions aren't apparent. So we have to create a flexible, goal-focused program in terms of addressing issues surrounding activities of daily living, exercise, lifestyle habits, and work. And now, again, I'm going to speak to osteopathy, but I feel that this applies for any manual therapy. I think one of the big things that I have at my disposal is time. When a patient comes to see me, I get them for a whole hour. And I appreciate that for a lot of doctors and other practitioners that they don't have that luxury. So I feel that that creates a relationship that's not always possible in certain situations in terms of the ongoing communication with the patient. So I think fundamentally osteopathy, we like to at least set ourselves apart in theory with the concept of touch. We use palpation, and it's not just a therapeutic intervention, but it is a way of communicating, and it's the core of the osteopathic examination and treatment. We use it as a way to communicate. I feel that it's also an avenue for patients to be feeling that they're listened to in a way that you're present. So sometimes some of those communications, the ability for the patient to feel that they're being heard. It definitely sets the environment and the context to treatment and for healing and change. That's definitely one of the positive outcomes I find, is that if someone can then take away some positive, that moving forward they're moving and changing some aspect in their life, then that's a positive treatment outcome. We use gentle and very patient-centered techniques that focus on the whole person and definitely looking beyond the musculoskeletal system in a neurological, somatosensory, and psychosomatic point of view. But as much as I say this is a philosophical thing that we like to feel is unique, there's no reason why these tools can't be applied in any other manual therapy. So I want to then move to more the exercise. So mindful movement, to be able to build a progressive and daily practice. So this is the other hat that I wear as a kinesiologist, and in some ways I feel most important because I feel that it's underutilized within the population. So a lot of the times the places I start is with breathing, something we take for granted, but that proper breathing mechanics can help to improve our core activation, pelvic floor function, I know that's a topic that's coming up, spinal stability. It can help with relaxation and focus. It can improve even some of our internal organ function by improving pressure regulation. It decreases the use of some of our accessory spinal muscles and can improve neck pain even by changing some of the breathing techniques that we have. From an exercise point of view, the idea of moving from a point of balance and presence and being an objective observer of ourself. I don't always try to impose whatever proper posture biomechanics. We have to work within the spectrum of that patient from wherever they are at this moment, and again, trying to move them towards what we feel is, a better position, but increasing their strength, motor control, and balance. And it has to be gradual to improve their adaptability and resilience using functional exercise and activities of daily living. Some of the tools that I feel are applicable in the EDS population are listed here. So the first one, which I do use, which is called dynamic neuromuscular stabilization. This is a method of exercise that is taught around the world, and there's many courses available in Canada, US, and it's out of the Prague School of Rehabilitation. And the premise behind it is that you're working on stabilizing the core and the spine, working on centering joints within their socket and learning how to stabilize using breathing as one of the main ways to activate those muscles. It's based on the concept that when we're born and we start to develop our spine and start to develop our strength, that there's that certain process that we expect. Babies on their stomach, they start to learn how to raise their head, and they learn how to reach, and then they learn how to roll, and the process of crawling, and then learning how to walk. And the idea that these are innate neuromuscular patterns in our body, but due to injury, those patterns can be altered. So we're taking somebody back and to help reintegrate some of those movement patterns that can help then in developing and strengthening the joints in the spine. Some of the other available exercises, Pilates, that's something that, again, I use. And there's Tai Chi, the Feldenkrais and Alexander techniques. Yoga, which I gave an asterisk to because I know it's something that's very available. And there's some positive qualities in terms of breath work, body awareness. But again, as we've talked to dance and gymnastics and all those bendy type of activities, I don't advocate for attaining poses and positions that are held. And again, when you don't have inherent joint stability, it's not advisable. So extracting some of the positives, which could be surround some of the strength exercises or, again, breathing and core. Aquatic therapy, I think, is, again, an excellent tool because of the fact that you're taking the body out of gravity, building cardiovascular endurance, strength as well, and just being easier on your joints. Walking, stationary bike, arm-ergonomer. Another tool I use is Nordic poles as well to help with cardiovascular training, but even gait when we're looking at retraining gait mechanics. I use the stability ball, balance exercise, TheraBand, hand weights. So to me, a lot of those things can be involved in a home program as well. So inexpensive, accessible, doesn't always, again, require anything fancy to improve strength and proprioception. And of course, the biggest, which I think is actually the most handy, is daily life. And working with people on sleep habits, work habits, school, positioning, ergonomics, some of the dealing with exercise, intolerance, and learning about pacing. So a lot of things that can be done in a very gradual way, in a problem-solving way. So now, again, it's been mentioned a lot. I do sort of have a passion of this interprofessional collaboration idea because a lot of the times working in private practice, I fall outside, again, both the scope in terms of the medical system, in terms of specialists and all of the maybe inpatient type activities and programs. And so I fall out of that from both in a physical sense, but also financially for patients because I'm in private practice. So my services aren't covered under any healthcare OHIP base, so it's private. So it presents an obstacle. But these are some of the big players, which again, I'm not going to spend much time on, but that should be part of that entire team. So work to be done. Again, I feel that we need still to be working towards that integrated, multidisciplinary, process-centered approach to the ongoing management. It is a spectrum, so I get the opportunity to work with people in that spectrum, and that early treatment will decrease the healthcare costs and quality of life. And then I pose more questions out to the other people in the audience as to how we can make this happen, to integrate more services to allow people to function better within the community. So the last thing is a book that I suggest all the healthcare professionals to grab a copy of. And this book by Ronald Epstein, he's a doctor in the US, and he wrote this book, just again published this year, on really exploring the foundations of mindfulness in medicine. So I do like quotes, so I'm going to leave you with one last one. So this one's called Beginner's Mind, and he talks to the idea here that beginner's mind uncouples expertise from one's present experience, and an intentional setting aside of the knowledge and preconceived notions that one has gained from books, journals, teachers, and past experiences to see the situation with new eyes, and that by simply setting my expert self aside helps me to consider new possibilities, and then I seek the evidence to justify or refute my initial impressions. So I strongly suggest that for our EDS population that we continue to look at these patients with beginner's mind, to be creative, to be open to new ideas, to learn how to better treat them. Thank you very much.